Welcome! We're diving into a rapid, visually guided review of the key primary central nervous system tumors, all geared towards real-world clinical correlation.
So, here's our game plan for this explainer. We're going to start with some key pediatric tumors, move into the major adult gliomas, touch on a few others, and then wrap it all up with some high-yield clinical pearls. Let's get started.
First up, let's talk about pilocytic astrocytoma.
Okay, so what are the key takeaways here? Well, first off, this is a WHO grade 1 tumor, which means it's slow growing. It's actually the most common benign CNS tumor you'll see in kids, and it typically pops up in the cerebellum. Clinically, you'll want to remember it's associated with BRAF mutations and it's GFA positive.
Now on the radiology, this is just classic. You really can't miss it. On this MRI, what jumps out is this large cystic mass right in the cerebellum. But the real diagnostic clue, the thing that screams pilocytic astrocytoma, is this well-defined enhancing mural nodule inside the cyst wall. Let's actually zoom in and take a closer look at the histology of that very nodule.
And when we get down to the microscopic level, two features really define this tumor. First, you see these elongated bipolar cells that look kind of like hair. That's where the pilocytic part comes from. And second, you've got these bright pink corkscrew-shaped things called Rosenthal fibers. See them? Those two together are the histologic hallmarks.
All right, moving on. Next, we're going to cover two really important pediatric malignancies that also hang out in the posterior fossa, medulloblastoma and ependymoma.
So, if the pilocytic astrocytoma is the benign player, medulloblastoma is its malignant counterpart. This is the most common primary malignant brain tumor in children. The big thing to worry about here is its tendency to spread through the cerebral spinal fluid, what we call drop metastasis. But on the flip side, it is extremely radiosensitive, which is key for treatment.
The imaging here really tells the story of its location. You can see on this MRI, the mass is sitting right in the cerebellar midline. And look how it's compressing the fourth ventricle. That can easily lead to obstructive hydrocephalus. Now, let's see what it looks like under the microscope.
Histologically, the finding you absolutely have to know is the Homer-Wright pseudo-rosette. You've got these small, round, blue tumor cells that are arranged in a circle. Now let's get in real close here. Notice how they're all surrounding a central, pinkish, fibrillary core? That is the classic textbook appearance.
You know, these days, it's not enough to just identify the tumor. The molecular subtyping is absolutely critical for prognosis. The WNT-activated type, well, that has the best outlook. The SHH, or sonic hedgehog type, is intermediate. And then there's the non-WNT/non-SHH group, especially those with MYX amplification, and they unfortunately carry the worst prognosis.
Okay, let's switch gears a bit to our second pediatric malignancy, the ependymoma. A really interesting feature here is how its location changes with age. In adults, it's typically a spinal tumor, but in kids, you'll find it in the posterior fossa, often causing hydrocephalus. It does like to recur, but probably the single most important negative prognostic marker we have today is the presence of the RELA fusion protein.
Histologically, the one thing you absolutely have to recognize is the perivascular pseudorosette. Let's look closely. See how the tumor cells are arranging themselves around blood vessels? They create this distinctive cell-free zone right next to the vessel wall. That pattern right there is what defines the tumor.
Okay, so we've covered the key pediatric tumors. Now let's transition into the adult world and talk about the most common and frankly most feared primary brain malignancies, the gliomas.
And we have to start with the big one, glioblastoma, or GBM. This is a WHO grade 4 astrocytoma. To put it simply, it is the most common and, unfortunately, the most aggressive primary malignant brain tumor in adults. It's defined by its aggressive nature and very poor prognosis.
Radiologically, you sometimes see this really classic and pretty grim finding. They call it the butterfly glioma. You can see it right here, this large, necrotic, ring-enhancing mass that has just infiltrated right across the corpus callosum, hitting both cerebral hemispheres. And look at all that surrounding edema. That contributes hugely to the mass effect. But the true histologic hallmark of GBM, it's pseudopalisading necrosis. If we zoom in on the slide, you can see these hypercellular tumor cells just lining up or palisading along a winding central area of necrosis. This pattern is pathognomonic for glioblastoma. It's super important to understand that the IDH mutation status really splits GBM into two different diseases. IDH wild type is what we call the primary de novo form. You see it in older patients, and it makes up about 90% of cases. IDH mutant, on the other hand, is secondary. It shows up in younger patients and often arises from a pre-existing lower-grade glioma.
All right, next up is oligodendroglioma. This one is really defined by its specific molecular signature. To make the diagnosis, you absolutely need two things, an IDH mutation and the 1p/19q codeletion. That's a requirement.
And the histology is unforgettable. It gives us this classic fried egg appearance. Let's focus in here. You can see these really uniform round nuclei, and each one is surrounded by a clear halo of cytoplasm. It all sits in this background of delicate branching capillaries that kind of look like chicken wire. That combination is classic oligodendroglioma.
Okay, let's move away from the gliomas and look at a couple of common benign tumors that arise from the structures around the brain, meningioma and schwannoma.
So meningioma. This is the most common benign CNS tumor in adults. A few key things to lock in. It has a strong female predominance. It comes from the meninges, it's linked to the NF2 gene, and, this is a big clinical pearl, it has progesterone receptors, which explains why it can grow so fast during pregnancy.
And on the MRI, you get this beautiful pathognomonic sign, the dural tail. Look at this dural-based, intensely enhancing mass. That little tail you see is the linear enhancement of the dura right next to it, and it shows you exactly where the tumor is coming from. It's a classic feature.
Microscopically, it's a classic 1-2 punch. First, you've got these whorled sheets of meningenthelial cells, and second, you have these laminated, calcified structures called psammoma bodies. The combination of these cellular whorls in the psammoma bodies is highly characteristic.
Next up, schwannoma. When you hear cerebellopontine angle tumor, this should be the first thing that comes to mind. It usually arises from the vestibular part of cranial nerve 8, and if you see them bilaterally, that's pathognomonic for neurofibromatosis type 2. Histologically, it's got two distinct zones, dense Antonia A areas and looser cystic Antonia B areas.
Now, for a brief but really important look at primary CNS lymphoma.
The biggest association to remember here is an immunocompromised state. Think HIV or transplant patients. It's typically a diffuse large B-cell lymphoma, and in HIV-positive patients, it's strongly linked to EBV. The really unique histologic finding is this hooping pattern, where cells are arranged in circles right around blood vessels.
Okay, to wrap things up, let's just run through a few high-yield clinical pearls and classifications that kind of tie everything together.
First, the fundamental WHO grading for astrocytomas. You just have to know this. It directly reflects how aggressive the tumor is, starting from the relatively benign grade 1 pilocytic all the way up to the highly malignant grade 4 glioblastoma we just talked about.
And what about prophylactic craniospinal irradiation? Well, you use it for tumors that have a high risk of spreading through the CSF, right? So that definitely means medulloblastoma to deal with those potential drop metastases. But the same logic also applies to other diseases with high rates of CNS spread, like small cell lung cancer and acute lymphoblastic leukemia.
And finally, two really critical clinical syndromes you don't want to miss. First is meningeal carcinomatosis. That's a diffuse seeding of the meninges, most often from breast cancer. And second is Durée hemorrhage, which is a fatal brainstem bleed caused by downward transtentorial herniation.